It's great to have you all here today virtually. I am Saffron Caudry. I am Deputy Chief Executive at NHS Providers, and I've also been the executive lead at NHS Providers on all of our work around health inequality since we kicked it off a few years ago. Few things to say before we get into the real business of today, and that is firstly to note that this session will be recorded. That's to make it accessible to others once the session has taken place. And also just want to tell you a bit about NHS Providers in case you are new to us. So we are the membership organisation for trusts and foundation trusts, and we work with them to help them deliver high quality, patient focused care by enabling them to learn from each other, act as their public voice. You may have heard us in the media quite frequently, and also helping to shape the system in which they operate. Our Health Inequalities programme is really focusing on supporting trusts to make sense of health inequalities and helping you really to embed that as part of core business. And we develop resources, webinars, other materials, which is informed by our own research and engagement with trust leaders over previous years. Can I have the next slide, please? So what we're going to look at today is really important elements focusing on health inequalities experienced by children and young people. And we're going to work our way through the NHS England's Core20Plus5 framework, looking at good practice from trusts and also focusing on how trusts can really reduce health inequalities faced by children and young people. We've got a brilliant lineup of speakers today, and I'm really delighted that they've all been able to join us. So a quick lowdown there before we move into the session proper. So we've got Professor Simon Kenny, who is the National Clinical Director for Children and Young People at NHS England. We've got Kerrie, a Youth Forum member from NHS England. Particularly warm welcome to Kerrie, and thank you for joining us. We've got Ajit Abraham, who's Group Director of Inclusion and Equity at Barts Health. And we've also got Kath Evans, Director of Children's Nursing at Barts Health. And then we've got from Gateshead, we've got Dr Judith Reid, Children and Young People's Diabetes Service Lead. And we've got Jenny Foster, who's the Network Manager for Children and Young People's North East and North Cumbria Diabetes Network. And she's from Leeds Teaching Trust. So we've got a great lineup. Can I move us on to the next slide, please? So I've already indicated that the meeting is being recorded. We would ask you to keep your camera on if you feel able to. Quite clear here, if you lose connection, just come back in, and please do mute, because otherwise we get a lot of background noise. We really encourage you to use the chat box to ask questions. You can also raise your hand during the Q&A discussion, and we will bring you in so that you can ask a question in real life rather than virtually. And really importantly, because we know that time is short on these sessions, any unanswered questions will be taken away and answered after the session. And that is important to us because we can't get to everyone, but we know that questions are really valuable. You will also receive a link to an evaluation form at the end of this session. Please do take the time to complete it. It sounds a bit trite to say we really value your feedback, but we genuinely value your feedback because it helps to shape our future sessions, and we really do learn and take on board what our delegates tell us. So without further ado, I'm going to introduce our first speaker, and that is Professor Simon Kenny, who is the Clinical Director for Children and Young People at NHS England. And he's going to give us some of that context on the development of Core20Plus5 framework for children and young people. Once he's spoken, we will move on to the next speaker. We're going to make sure that we have a wide-ranging Q&A. at the end of all of our speakers, because we find that that's the format that works best. But please do keep your questions coming. We will keep track of them. Okay, over to Simon.
Thanks, Saffron, and thanks everybody for taking the time on a beautifully sunny day to join us to talk about this. I suppose my role in this is to sort of act as a bit of the fourth horseman of the apocalypse. So I'm going to sort of set the scene as to why this is a really important problem. So essentially, the pandemic brought a harsh light on the role of inequalities in determining health outcomes. And I'd really like to pay tribute at this point to Bola Owolabi for her leadership and vision in terms of raising this as an issue, both across NHS England and nationally, with regards to health inequalities. And she formulated the Core20Plus5 for adults. And really pleased that within that, there was a focus on maternity, and obviously the predeterminants of child health start with maternity and neonatal services and safe birth. But we sort of met with Bola and the health inequalities team, and in the course of 2020-21 formulated the Core20Plus5 for children. And I suppose just a few things to say about this. So the Core20 is the 20% most deprived of the population. The +5 is sort of 5 core conditions that we took as indicative of areas where you could take action. And the plus element is around any characteristics that a child or family may have that won't play a role. And an example of that would be coming from a travelling community or having parents who have a substance abuse history or something like that, which sadly many of our children have. We were conscious of problems with health inequality, obviously long before the pandemic, and many of the seeds of the problems were set well before then. But essentially, for every decile that you drop down in terms of deprivation, child mortality raises by 10%. And the slides, which hopefully we'll find in a sec, will demonstrate that. But that clearly is the tip of a very large iceberg in terms of quality. Child mortality is thankfully rare, but where we see that influence of deprivation on mortality, it gives us a massive signal that there's problems in terms of quality and access to healthcare across the system. And after the pandemic and during recovery, we're also conscious of the fact that children are being left behind compared to adults. And one of the protected characteristics that we have is age. And so we're working very hard with NHS providers to sort of raise the profile of children in terms of elective recovery post-pandemic as well. So that they aren't treated inequitably on the basis of age. So when we sort of formulated the Core20Plus5 for children, we worked with health policy experts and public health experts to work through what areas that we would take on board as part of that 5. And it really is intended as just as a starter and to get models of care that can influence how care for all children that we look after can be delivered. And also conscious of the fact that they were very NHS focused. So we looked at problems which were totally within the gift of the NHS. And it will become obvious as you see them, and I'm sure you know them already, it will become obvious that we are looking at very NHS focused. And many of the significant determinants of child health are actually sit outside of direct NHS intervention and sit in a wider audience. And a really good example for that is child obesity, where we've got 2.5 million children who are obese, and we can see the signals of deprivation and ethnicity playing through in that particular group as well. So the areas that we chose, and we also wanted to make sure that we had equity between mental and physical health, because for too long there's been an artificial divide between mental and physical health, and to a certain extent we've enshrined that in NHS structures. So very keen that we take a holistic approach when looking at child health and inequalities. So the areas that we chose, and some of them are going to get focused on, I'm sure Kath and Judith will allude to it later on, was around oral health, because in the pandemic we suddenly saw a massive reduction in tooth extraction. And that is the end of a long journey, because the annoying thing about oral health is that when it comes to removing children's teeth, it's an entirely preventable disease. So we're dealing with something of a public health failure as well as a capacity issue as we came out of the pandemic. And you could see that there was a 70% reduction in procedures, and we've never quite got back to what we were in terms of those procedures being carried through. Many of the children who were due to have tooth extraction in 2021, their teeth will have fallen out by now. I'm more worried about their secondary and adult teeth, to be honest, in that particular group. But we felt it was a really important area to focus on. The second area was in mental health. And when you look at the signals in with regards to deprivation, but also ethnicity, you can see that with deprivation, we can see an increase in demand in lower socioeconomic groups for mental health problems. And that's probably a little bit of chicken and egg in that situation. And also with regards to ethnicity, there's some worrying signals about certain communities, such as Asian communities, not necessarily having the same demand for mental health services, or at least not playing through so that they're receiving the care that they need. The three other conditions we chose were long-term conditions that affect children, and the first of those is asthma, which is a complex area, which and we've seen in the last year with public inquiries the role that air quality has in terms of determining asthma. There is potential new advances in terms of things like RSV vaccination that we might see might dramatically reduce asthma incidence in our population. But as things stand at the moment, you can see that your risk of having an acute hospital admission is significantly high with asthma compared to being the least deprived deciles. And you can also see when you look at processes of care measures that, again, that same deprivation signal plays through. And a similar picture exists with ethnicity. And it's very difficult to unpick ethnicity and deprivation and find out a single particular cause, but we know that they're both very influential in determining outcome. Similarly, when you look at diabetes, you can see that the use of continuous glucose monitoring and insulin pumps varies significantly according to deprivation groups. And so with an increased incidence in the most deprived. And similarly, you can see with Black and Asian communities, reduced access to those devices. We are at a sort of pivotal moment with regards to children's diabetic care, where we can potentially extend closed loop systems, which the evidence base supports really strong and tight glycemic control. And that means good long-term health outcomes by employing those devices. But as we start to bring those devices online in the next few years, we need to be very cognizant that we need to reach the most difficult to reach populations, because that's where the health benefit will be seen. And another area of interest in diabetes is around the tripling we've seen in the incidence of type 2 diabetes in the last decade, which was an unheard of disease a decade ago, and now as a consequence of obesity, we're seeing that. And we know that over half of children that we're seeing with type 2 diabetes are in the most deprived decile. Within epilepsy, it's a very similar picture. So we know what works in terms of delivering high quality care for epilepsy. It's having good access to epilepsy nurse specialists. It's having access to tertiary opinions and specialized surgery when required. Sadly, we see signals with mortality with sudden death in epilepsy in children, and that there is again a socioeconomic gradient and an ethnic signal that's seen in that data as well. And then I think I've done the 5 now actually, which is amazing because I've done it without any slides. So that is the scene, and so the Core20Plus5 is specific actions against all of those 5 areas that I've mentioned. The final thing I'd like to say, and I'm conscious that I'm talking to NHS providers, which is the group of people I really want to talk to, and it's about how we treat our families when they bring children to hospital. The cost for bringing a child to hospital is around about 30 to 45 pounds for a family, and with the financial straits that many families find themselves in, it's hard to underestimate what a significant issue that can be. And I worry more now about the patients I don't see in my clinic than the patients I do see, and the reasons why they haven't turned up to clinic is really important. And when children and families are in, I think the work of Sophie's Legacy, which is being worked through at the moment, in terms of making sure that those families have access to food and sustenance when they are in hospital, and a good play environment, and an environment that cares for children, is really important. And particularly in the early years, where we know that if we show love for the children that we have under our care, it's one bit towards creating a healthier and wealthier society in the future. So apologies for not having the slides, and I'll pass back, and happy to take questions at the end. Thanks, Saffron.
Thank you so much, Simon, and what a tour de force to do that without your slides. We will circulate the slides after the session, so you've got them as a record. But thank you so much, Simon, and I think really important to understand where the Core20Plus5 for children and young people comes from, and the areas it's covering and why. And I think, you know, that final point you make about how we support families in our care feels very important. So thank you for that, Simon. And yeah, really well done again for doing it without the slides. I'm now going to ask Kerrie to make a contribution. Kerrie is a Youth Forum member, part of NHS England's Youth Forum, and she's going to share her experiences of healthcare services and also working with NHS England on health inequalities and Core20Plus5. Thank you so much, Kerrie. Over to you.
Hi everyone, thank you, Saffron. So I'm one of the 7 youth board members. In the last year, we've done some work regarding Core20Plus5, which has included advising on how to make the infographic more youth-friendly. And we also presented last year at the youth board about Core20Plus5. Next slide, please. So there's a staggering amount of young people who believe that their disability, ethnicity, or gender identity has had a negative impact on our health. We believe that Core20Plus5 is incredibly important for young people, and it's vital that we now work on raising these voices and making sure they're not neglected in a healthcare setting. Next slide, please. So you'll see some quotes on the board, and I do ask that you have a look at these and take them in, because young people are our future. They're the future of the NHS, future of our economy and the world as we know it. It's so important that we tackle young people's issues, make sure they're included in a healthcare setting and raise their voice. If we tackle problems now, we can minimise them later in life and make sure that nobody is excluded. Thank you.
That's fab. Thank you so much. And I think those quotes are I think really, really helpful and impactful. I wonder if we could just go back to those quotes, if that's possible, just to spend a little bit more time so we can see them, because I think that they are so important to think about those different aspects. And I think, Kerrie, you highlighted the importance of those really well, but I just think if we take a moment to look at those, because I think it will really inform our conversations later. Okay, thank you for that, and thanks so much for your contribution, Kerrie. I'm going to move us on now to our next presentation, which is from Ajit Abraham and Kath Evans, and they will be sharing the work done at Barts Health to improve services for children and young people, specifically targeted at reducing health inequalities. So over to you two. Thank you so much.
Thank you very much, Saffron. I'll kick off if that's all right. And thank you to NHS providers for giving Barts Health this opportunity to point to some of the work that we're doing. So we are very grateful. I'm a hepatobiliary surgeon and a trauma surgeon. And for me, the connection between the work that I do, frontline work that I do, and as Simon and others have alluded to already, the obvious impact of the determinants of health on those outcomes has been self-evident and not to be ignored for a very long time. So I'm very privileged to be in a role which actually intentionally combines inclusion and equity in a way that hopefully we can make some sense of to all of you. So as Saffron pointed out earlier, it's all about our patients, but we also recognize that the people who care for our patients and the partnerships that we have with the communities that we serve are critical to ensuring that our patients get the most high quality, safe and compassionate care that we can deliver. And our We Belong strategy informs and underpins some of what we're trying to do. And whilst I don't wish to get into the detail of all of what's on this summary slide, you will, if you look at the 3 columns, see that running through all of it, there is a very firm commitment to fairness and equity in terms of how we engage in care provision for our patients, but also in terms of our staff and our partnerships. Could I have the next slide, please, Annabelle? I'm conscious that I'm only the warm-up act for the wonderful Kath Evans, so I'll be as brief as I can. Can we go to the next slide, please, Annabelle? We have a very small but wonderful team that's responsible for addressing inequalities in healthcare. Some of you may know Dr. Ian Basnett, who is our Group Director for Population Public Health in-house and is a friend, mentor, and colleague. And he is also supported by our Associate Director, Kate Turner and Angela Camp. So it's quite a small team with some support from rotating public health fellows. And I mentioned them because I'd actually explicitly told Kate to put their names on the slide, and in a characteristic self-effacing way, she hasn't done that. So we're indebted to them to all the work that they do in the context of current constraints and challenges. And essentially our focus is around these 4 areas: equity focus. There's the prevention work that you will all be familiar with around tobacco, obesity, drug and alcohol addiction, and so on that goes on. There's a massive piece of work that's led by our Deputy CNIO and CNO, Louise Hicks and her team around community partnership and engagement. Andrew Adfield is our director for the Anchor organization work, and later on I can speak to the detail of some of this if people are interested. And then there's clearly an equity of care piece around what we can actually do as an NHS acute provider in collaboration with our partners to improve the equity of care that we provide for our patients, looking at issues around access, experience, and outcomes. And next slide, please, Annabelle. So just to talk about what we're trying to do through our We Belong strategy, and I think both Simon and Kerrie and yourself, Saffron, have alluded to this, matters of inclusion impact directly on our ability to provide equitable care for our patients and also the communities and population that we serve. So we've very deliberately recognized that we need a strategy that addresses inclusion within our organization, which is critical to the well-being of our staff, if you like, and a sense of belonging for all of our staff. And we hope to create, both through formal and informal leadership structures, a culturally intelligent, inclusive leadership community that can build a fair and just culture that allows us to live by our We Care values. And the whole focus of all of this then is to deliver equity for our staff, but also equitable care for all the people that we serve in North East London as the largest acute service provider in Northeast London. So that informs everything that we do. And what I'm pleased to see is that increasingly we are, in everything that we do in terms of our clinical and operational deliberations, actively trying to think through the lens of inclusion and equity about how we frame some of the challenges so that we don't overlook things inadvertently that are critical to providing this kind of inclusive and fair care for people. Okay, next slide, please. So this is just a quick overview of some of the things that we are currently doing, that we fully recognize that there is so much more to do in this space, but I think there are very positive beginnings, and that just to call out a few. I mean, we have got to a point where we can now look at deprivation by postcode And clearly, when you layer on top of that all of the protected characteristics, including ethnicity that has been touched on already, you can start to see how deprivation gets amplified by everything else that then plays into the equation around the health and healthcare that people are able to access. And now some of these are now available to our clinicians in terms of the equity e-learning module and our ClickView application. Still a long way to go, but it's the key to, I think, getting people involved in care across multidisciplinary professional groups to start to think about these things in terms of equity and fairness. We've done some outstanding work. Tony, Joy, and the team have done some exceptional work around the REACH stuff that has won national awards. But what I wanted to highlight was even within that work, we were very careful from the outset to look at the equity around ethnicity and other provisions within that REACH work in terms of ensuring that there was at least a lens on fairness in all of that innovation. There are obviously preventive things going on. There's a lot of work going on around equity of access and experience, patient persona work in the community. We've done some really excellent work around learning disabilities that Kath may call out in a little bit more detail. So I won't get into that space at the moment. And there's clearly a lot of work to be done in terms of working in partnership across our Northeast London patch in terms of the place-based work that each of our hospital sites do and some of the work with primary care, mental health, and the community partnerships that we have already established. So that's a very quick run through. I'll be happy to take questions later on. I'm very pleased to hand over now to Kath. Thank you.
Thanks, Ajit. And I think one of the critical things that we're really good at in child health is often working in isolation and in a bubble. And I think working with colleagues such as yourself, Ajit, and also the public health team and the broader executive team within organisations is absolutely critical if we can move the framework forward in addressing child health inequalities and making those connections. And I don't know as to whether we can move on to the next slide, because that then brings to life how we've shared the Core20Plus5 across Barts Health. And we utilise mechanisms such as the Quality Governance Forum to share our annual report and to raise awareness of this national framework. We've taken it along to the Barts Health Inequalities Committee, but also we've shared it and we've been working in partnership with our broader integrated care system colleagues. So really engaging with our directors of children's services, our community providers, and also our voluntary and community sector organisations as well. And I suppose if it's one top tip for us as paediatricians, as senior children's nurses, it's to reach out to our allies to really move this agenda forward. So if we can move on to the next slide, it'll begin to explain how we've really tried to move this forward. And one of the really lovely things hearing from Kerrie today from the NHS Youth Forum and as a youth board member is the voice of children and young people, and really keeping focused on what matters most to them so that we can work in partnership. It's often their narratives that can be incredibly powerful. And one particular group that we've been working with that's identified in the Core20Plus5 CYP framework are those who are care experienced. So we've got 16,000 young people who have been in care across the whole of London. We've gone out to our local authorities and spoken to our children in care councils and very much worked in partnership with them and been part of a broader system piece of work to ensure that we've got a Care Leavers Compact, which we are hoping will be launched later on this year by the Mayor of London. And within that is a health component, including access to prescription medications. 5 of our integrated care systems across London have all signed up to supporting care leavers when they do need prescription medications. And I think there are some significant challenges. Simon's already alluded to the challenges with regard to mental health. 50% of all of our care leavers experience mental health challenges. Many of them require access to prescription medication, and we need to be supporting them with that. So that's just one example where we've been able to harness the voice of young people, focus on what matters most to them. But the other element is also focusing on the voice of families as well. So we know that within Tower Hamlets, one of the boroughs that we serve, the most shoplifted item in our community is Calpol. That's hugely significant. We also work with one of our local London charities, and they've identified that some families are limiting the use of one nappy a day for their children. So how do we work in partnership and think about access to baby banks, and how are we actually signposting our families with regard to those services? We only have to walk around our local supermarkets, and what we're now seeing are baby milk formulas being security tagged as well. So it's the reality of that narrative that's been really powerful in making sure that we're all aware of the challenges that our children, young people and families are facing, so that we can work in partnership to move this forward. Don't know as to whether we can move on to the next slide, which begins to identify some of the work that we've been doing with regard to our models of care and really taking forward that opportunity to build health equity. So we've got a wonderful charity, Barts Health charity, who have supported us in testing a model of social prescribing in secondary care. Predominantly, it's been focused in primary care, but we've been able to test that role, particularly with regard to our young people who've got sickle cell disease and those with medically unexplained presentations. And there have been some magical direct outcomes. One of our paediatricians over in Whit's Cross Hospital has developed with our safeguarding team a social deprivation screening tool, which is purely called Times Are Hard, to have conversations with families about how we might better support them. That's going down really, really well. What we have found is that we've got some significant challenges with regard to health literacy. So actually conversations are often more powerful than questionnaires as well. And also, Simon's already alluded to the importance of Sophie's legacy. It's a wonderful 10-year-old young lady with a rhabdomyosarcoma who sadly died, but had a lot of hospital admissions during her short life. Really wanted families to be fed and to be cared for as well. And not only across Barts Health, but across North East London, we've been working to actually ensure that we are fulfilling Sophie's legacy and really taking that forward. And on the next slide, it also allows us to connect with some broader opportunities as well. So many of you will be very familiar with the rollout of virtual wards. What we've now got are hospital at home facilities across North East London. Again, as Simon alluded to, the cost of hospital admission is significant. We know that an outpatient attendance, costs generally about £35 for a family to attend. I do think that's a rather conservative estimate when you take into account all of the travel and food issues, etc., childcare, time off work. What we've been trying to do is work towards keeping care at home and as close to home as we possibly can, from both admission avoidance, but also from an outpatient's perspective with regard to further integration with our primary care colleagues. We've certainly got much more to do on that agenda. Ongoing work around asthma, epilepsy and diabetes, and I'm really excited to hear about the poverty proofing work that we're going to hear about very shortly. But within diabetes, the family liaison role has been absolutely critical in really reaching out to our socially and economically vulnerable family groups to enhance use of technology and to improve clinical outcomes as well. So those family liaison roles have been absolutely vital. Further work on was not brought and really understanding it's not always about our admin processes. It's also about how we better support our families to attend. And we've also been working with our library services as well. So we've now got a monthly bulletin that goes out with regard to child health inequalities, and we've been doing some work, our library services have been doing some work to really build up knowledge about the challenges related to health literacy, both from a family perspective and also from a children's perspective. So I'm hoping that that's given you a little bit of a flavour about the work that's been going on very broadly. What I would say is that having a national framework has been really helpful for us. It has allowed us to share that evidence base both within the trust but also at the integrated care system level. So I'm going to hand it back to Saffron, if that's okay.
Fab. Thank you so much, both Ajit and Kath. I mean, it gave us the great strategic setting in terms of what Barts is doing, and then some of the really getting into the practicalities of how you are putting that into action. So really fantastic. I'm going to move us straight on, remembering everyone that there's the opportunity to ask questions in the chat, and we will come to the Q&A after our final set of speakers. So we're going to now turn to Dr Judith Reid and Jenny Foster from Gateshead Health, NHS FT and Leeds Teaching Trust to talk about their diabetes initiative. So over to you two.
As I said, I'd like to acknowledge the collaboration with the North East and North Cumbria Diabetes Network, the Child Health and Wellbeing Network, and the North East and Yorkshire Children's Programme. Next slide, please. So our journey started pre-pandemic. The North East and North Cumbria Diabetes Network linked with the Child Health and Wellbeing Network to engage with delivering the priorities that had been identified following extensive consultations across health, education, social services, local authority, plus voluntary sectors, and most importantly, the children and young people, the families and carers. And one of these priorities was poverty. Next slide, please. One of the key partners in delivering these priorities was Children North East, who had poverty-proof school settings within the North East prior to the pandemic. And Gateshead Diabetes Service became the first healthcare setting to be poverty-proofed. Next slide, please. The poverty-proofing process involves first healthcare professionals doing an education session. Next slide, please. And secondly, healthcare professional interviews to understand the services, the challenges, and identify current good practice. If you're happy just to flick through this, there's a timeline of the poverty proofing, and I'll just talk whilst you're having a look at this slide. So thirdly, the poverty proofing process involved interviews with children, young people and their families and carers to understand the challenges of living with diabetes. And this included an agenda day which was funded, which was a focus group delivered by children and young people from the Type 1 Kids Support Group for other young children and people to provide their voice on living with Type 1 diabetes and poverty. Stage 4 involved Children North East then providing feedback to our senior team and ourselves, which happened in October 2022, and then a final report was published in February 2023. We're now implementing some of the recommended actions, and a final review of progress and feedback will be completed later this year. Alongside this, we've fed back to the regional leadership teams, and 2 of the other teams in Yorkshire have commenced the poverty proofing process. And Children North East have also developed a training package for healthcare professionals, which has now delivered 7 training sessions for all healthcare professionals involved in children and young people's diabetes care in North East and Yorkshire. I will now highlight some of the work we've done. Next slide, please. So we've developed a QR code directory which has been embedded across paediatric services in Gateshead, not just diabetes. And we're in the process of updating this with additional codes that we have identified through our work. Next slide, please. We provide free fruit and sugar-free juice in all waiting areas for children and young people. And this was a good practice that was identified through initial consultations. The Trust have continued to fund our new patient education programme, supporting standardised intensive management from diagnosis for all children and young people that are being diagnosed with diabetes. We've updated new patient packs with information to support accessing things like disability living allowance, and families had mentioned that For some families, they found this relatively easy, but for other families, particularly where they didn't have the time, they didn't have the understanding, they might not have had the language skills. Often there was a inequity in how disability living allowance was allocated. In addition, we include patient and family support information within these packs as well to ensure everybody had the opportunity to get that support. We've prioritised education on dental health for healthcare professionals, and that we've done that regionally, but also for children and young people and families within clinic. And that addresses one of the Core20Plus5 identified areas. And children with diabetes, and particularly those children with diabetes and living in deprived areas, do have the highest risk for poor dental health, particularly with all the glucose treatments and hypo treatments that they may be taking. Next slide, please. I've worked collaboratively with our Trust Diabetes pharmacist and regional diabetes leads to write an application to the Regional Medicines Committee for access to hypoglycemia treatment for all young people living with diabetes on prescription. And in particular, this was an area that was identified by the young people in their focus group, and also addresses the Core20Plus5 dental health area for children and young people. Next slide, please. Next slide, please. In October 2022, we had the opportunity through the NHS England funding to address inequalities around access to diabetes technologies. This was a large focus in our poverty proofing report and feedback from families. Regionally, after reviewing the North East North Cumbria data, we identified that deprivation was the main priority to address in the North East and North Cumbria. And the North East and North Cumbria Diabetes Network, we were already aware, and teams had used different but unsustained routes of accessing digital technology throughout the pandemic. But as Simon Kenny mentioned, the first line of treatment for type 1 diabetes in children and young people is insulin pump therapy because of the need for intensive management and improving long-term outcomes. And soon we're going to have the hybrid closed loop automated pumps and the NICE mandate for implementing that with real-time continuous glucose monitoring, which is a NICE recommendation as well. And there's a big inequalities gap in access to this equipment. We did a successful regional application bid, and funding was given to develop a replicable process pathway for refurbishing NHS digital equipment for use with diabetes technologies. Next slide, please. We partnered with Town and Community, a charity who had experience with refurbishing laptops donated by Nissan during the pandemic for use in Gateshead schools. And they had a contract with ITAD, which was with an ITAD, device refurbishment company. And these people had the recognised IG processes and GDPR processes to meet the Trust's legal requirements. We also partnered with Type 1 Kids, our patient diabetes patient support charity, who've overseen the patient-facing side of the delivery of the project, including data collection. I provided the clinical involvement, but we also had a huge willingness from our head of digital solutions and technology services in Gateshead to reduce digital poverty in Gateshead. And this was essential to being able to deliver this project. They were quite happy as well for us to extend the project to deliver this project on a region-wide basis. In addition, the Trust was in the process of replacing digital devices across the Trust for security reasons, and I was aware of this and approached the digital team. And the Trust was also at the right time in their contract to be able to look at renewing this. So essentially, the timing was right, and we sought advice and linked up with the Child and Health Wellbeing Network Digital Divide Group, the Academic Health Science Network, the Digital Poverty Alliance. So this process, so with the pilot is midway through. We're 6 months into the pilot now. We've overcome significant challenges. diabetes devices have specific phone compatibilities, and some of the devices donated by the Trust were initially not compatible. We did a successful business case to the industry and sent a phone across to the US, and we were able to get the phones that the Trust had donated compatible to be used with the diabetes technologies that we needed. The challenge going forward is sustainability, and adoption across the ICB or across multiple trusts would enable a wider range of digital equipment to be available, and extension in the long term, once this pilot is finished, would be to other healthcare conditions and services. And thinking sort of what could be available to, you could do remote monitoring for blood pressure monitoring, enable virtual appointments. So across the ages, refurbishing digital technology has huge scope. To date, using a justice model of poverty proofing, access to all, 70% that have accessed this project are living in areas ranked in the lower three deprivation deciles. Next slide, please. Here are some examples of some.
Just a couple more minutes, Jude.
Yeah, no problem. Here's some of the examples of the patient literature we used. Next slide, please. I'll just highlight a couple of things on this quote. This one was actually from me, but downloading at home prior to clinic or real-time data transfer to the cloud from a phone enables clinics to run more efficiently, reduces the clinic-associated cost to the family by shortening clinic waiting times and therefore parking costs and childcare costs for other children and time off work. Next slide, please. This is a quote from one of the nurses about the quality of life and the improvement with a child with autism in his support staff at school and his respite staff being able to look at his glucose levels remotely on a phone that was outside his room. Next slide, please. And then much of poverty proofing can be delivered by healthcare professional teams at a service level with the appropriate training and education, such as the package delivered by Children North East. However, some solutions need strategic, trust board, regional support, such as the refurbishment of the digital technology if you're taking it sort of from a sustainability point of view. And things like access to hospital appointments also will need central team support or strategic support. Things such as enabling access to hospital appointments, so either free parking or free public transport, and methods to potentially be able to use to support that, but also thinking about adequate staffing ratios to facilitate more healthcare appointments closer to patients' homes. So I'll leave you with those thoughts. We haven't got all the solutions for those just yet, but thank you for listening.
Thank you so much, Jude. That's really, really fascinating insights into the work that you are doing in Gateshead and across the Northeast. Okay, I think we're now going to move to the Q&A panel session. So if I can ask that all of our panelists are spotlighted so that we can bring them into focus, and also yes, those who are here supporting but who haven't spoken as well. Jenny, you're very welcome onto the panel. I think that before we move to Q&A, I wonder, don't want to put Simon on the spot, but if he's here, I just wonder whether there's, just thinking about your opening remarks and then what you've heard from the kind of more detailed contributions there, and just your reflections on how delivery is kind of living up to the broader strategic aspirations.
Yeah, thanks, Saffron. And I think hopefully people will have seen during this that sort of link between a sort of national policy and actually delivery on the ground. And I think that Kath and Judith's example has just been really good at showing that. Actually, really quite exciting from our policy team perspective. Sophie Salty's on the call as well, who's played a really big role in developing the Core20Plus5 for children. And I think it's really good to see that. But I can't be complacent. I know that we've got we've got to replicate those kind of initiatives right across the country and maintain that sustainable change. I suppose what I didn't say is that integrated care boards have a statutory requirement to report on the basis of Core20Plus5. And I would hope that as providers, that would help you have discussions with those integrated care boards, because sooner or later, someone's going to sort of be asked about what they're doing about Core20Plus5 for children. And I think we've given them the tools. I think what you've seen with Kath and Judith's experience is that if you give the teams the tools, we've got the clinical leadership out there, which is really inspiring both across nursing and medical workforce to deliver.
Thank you so much, Simon. I suppose in asking you that question, I was particularly struck by the kind of golden threads running through what's going on, which, one doesn't always see. And so it kind of felt exciting for me to see that in action. I just want to ask an open question of the panel, really, on thinking about your interactions with your trust boards, and how you might have sold these initiatives internally, because I think certainly thinking about people we've got on the call, thinking about the challenges across the NHS, there are so many priorities, and even if something's mandated, how do you actually get it onto the agenda and get that get it through, basically? So just anyone who wants to come in on that, I don't know whether Ajit or Kath, you want to talk about. Ajit, shall I go to you first?
So I think we've been fortunate in that the role itself is on the trust board and reports directly to the group chief executive. So the inclusion and equity is center stage, and we have an inclusion and equity board that looks at these issues on a regular basis, and then feeds into both people and the quality assurance committee, and then that feeds into trust board. So there is a structure of governance that recognizes and respects that this has to be center stage, and I think that's helpful. I mean, things could always be even more effective, but that's a big step, I think, in the right direction. So that's one way in which we've, I think, been able to do that. Yeah.
Thank you. That's really helpful. And I suppose just to bring in Jenny, I wonder if, in terms of your interactions with your trust board, working both in your trust and then across the network, how that has played out.
I think from the point of view of the mobile phone project, which Jude has discussed in her presentation, it's really important for us to build relationships up with the IT departments and the trust boards and get them on board with the idea of refurbishing your unused NHS England equipment or trust equipment for the purposes of supporting the patients within the trust. And this has been really, really difficult. Jude alluded to the fact that Gateshead Trust have been extremely on board with delivering on this project with us. But we've found it really difficult, despite our best efforts, to engage other hospital trusts across the North East and North Cumbria region, to engage in meaningful conversations that would lead to us being able to get donations of mobile phone equipment. This project is a proof of concept. It does work. You can make it work. And that's what we're referring to it as now, as a proof of concept project. But engaging the people that matter to make these decisions has been really, really difficult. And being able to highlight it in places like this, we're hoping will be really helpful when we come to present the project at its conclusion next spring.
Fab. Thank you. And Kerrie, just wonder if I can ask you a question about how do you think trusts could work well with young people to hear their experiences?
I think with young people, it's really about being willing to listen to them, giving them the opportunity to speak as much as possible, having youth-friendly conversations, so making sure like any jargon you might be using that a young person might not know, just making sure they know everything you're talking about, and making sure that it's accessible for them as well, and really making them feel part of the conversation. It can be really hard for a young person to come to somewhere like the NHS and not feel overwhelmed. So it's really about making them feel comfortable, and just letting them be a part of the conversation.
Thank you. That's really helpful, and I wonder the extent to which that can be easier said than done. And I think the contribution of the Youth Forum and other structures will be really, really helpful in that. Another bit that is coming through in kind of the theme that is coming through is around, and I think it was probably Kath who said, and I'm interested in this, which is the notion that it's very easy to kind of, everyone works in their bubble, you know, and it's very easy to work in a bubble. And I just think teasing out some of that collaboration feels important. I think and I just wonder how you approached that collaboration with other sectors, how you burst out of your particular bubble and how you got others on side, just in a bit more detail, because I think that is, you know, collaboration in everything we do these days is the name of the game. So I think it would be helpful to hear a bit more on that.
Thanks, Saffron. I think there are a whole variety of those of us who work within child health of opportunities that we need to explore in terms of talking to our exec directors and getting them to actually walk the floor with us can be really, really powerful in terms of ensuring that they are advocating for and understanding some of the challenges that are being experienced by our children and young people. So both our non-exec directors and exec directors at Barts Health will, you know, come out, be present, be really visible in our children's services. And we can't always fix the world, and we absolutely understand that. But having that ability to have conversations is really, really powerful. So the other element that has been really useful to us as well has been joint appointments with our integrated care system as well. So in my role, I'm Director of Children's Nursing at Barts Health, but I also have the clinical lead role for our Babies, Children and Young People programme in North East London. And that's been really helpful in terms of, again, being able to share the narrative of what's happening in our ED, in children's outpatients, in our inpatient areas, and to really bring that to life with colleagues across primary care, across community settings, and also with our directors of children's services as well, to really work through some shared solutions. So only yesterday in North East London, we had our Babies, Children, Young People Executive Group, which is chaired by our SRO, our chief nurse. We were having conversations with the directors of public health around oral health, for example, and the fact that very sadly, we've had 2 recent deaths of young people where obesity has been a contributing element within the inquest report. So I think there's something about those broader connections as well at both trust level, but also at ICB level, that we've all got a responsibility as child health professionals to actually really pursue going forward.
That's really helpful. I'm just going to throw open the opportunity to anyone who is listening in to go on camera and ask a question. If you want to ask a question directly, just use the raised hand tool and one of the team will let me know that you want to come in. While you're mulling that over, oh yes, I've got a question. I don't need to go to the wall and mulling it over. I'm going to go to Helen Bennett and bring her in.
Hiya, thanks. I'm from Merseycare, working in the Northwest, and we have community and mental health services for kind of a large scale population really now. And I was interested in the case studies. Thank you so much. Really great to hear. But I was curious as to whether any of you have specifically approached this through a lens of being more sort of predictive and preventative. We've been doing some work in relation to complex families, an analysis through a kind of linked data set to identify children living within complex families, and I suppose earlier intervention and being more predictive. That's at a kind of population level, not a sort of individual case level prediction at the moment. And I wondered really, we know that, you know, we've got about 9% of all households in Liverpool have got children in them that have got complex lives because of the family and the environment. So it's really, how can we use that data in a more aligned way in order to get upstream on this? And I wondered if anyone had any specific examples of how they've done that.
That was a perfect question, because the question I was going to come on to was about using data. So that's fantastic. But Simon, you want to come in on that?
Yeah, thanks, Helen. It's a great question. I can't sort of speak about specific examples, but I suppose from a national perspective, we are looking at data very hard. I think so. For instance, we know the children who are most likely to be admitted with acute asthma. We know the work we've done with children with extreme weight in their clinics, that they are that very group that you're talking to, Helen, which have multiple agency involvement. But somehow the bits don't, there's no synergistic relationship. I think the Q clinics help that and mean that you get effective delivery of care and improvement, and the stories that are coming out of that are really, really strong. So children who've been not attending school, starting university and things like that this year, which is, must seem like a million miles away to someone in a low socioeconomic group not attending school to get to that. But that's the reality of what we can do if we can get our models of care right. So I think that moving forwards, the other bit, I suppose, is just about how can you do that without looking judgmental, and families won't want to be identified as those high-risk patients. So it's quite a challenge and a dialogue we've got to have, because there's already concerns about data, and if we start to sort of look like we're being judgmental, so the language we use, the way in which we use data, it has to be absolutely important. But it's incredibly frustrating to know that tomorrow we could take that data points and make a difference, and we can't yet. And these are the discussions we have to have.
Thank you, Simon. I'm going to bring in Jude, who's indicated she wants to come in, and then I'm going to move on to the next question from the virtual floor. Jude, over to you.
Hi, thanks, Helen. I think just thinking about it from a long-term conditions perspective, sadly, from a diabetes team perspective, those complex families tend to be highlighted when things aren't going so well. And it's very difficult to get the complex families the support they need early on. And it's often when there's a crisis or when they're not achieving their goals or there's safeguarding concerns that then we're able to get them the help they need. So I think, if we had a service that we could intervene sooner, that would be fantastic.
Fabulous. I'm going to move on to another question from Helen Merrick. It's clearly the day to be called Helen and ask a question, but Helen M, over to you.
Thank you. I'm sorry about my camera. I can't get it to work. I've tried, but it won't work, unfortunately. So my question was around engagement. So I've worked with young people in the past for a long time, and one of the biggest issues around engagement is actually getting young people to want to engage with you to kind of help shape services. We're trying to be quite creative in our team around different ways of getting the young person voice being heard. And I just wondered if anyone had got any good examples of where they'd managed to engage with maybe a different sort of set of young people, reached out to people that maybe young people that wouldn't have been heard previously, and any kind of good practice examples, really.
Kerrie, would you like to come in on that? And then I'll open it up.
Yeah, definitely. I know it can be quite hard to find young people who do want to engage, but I do think it's all about looking in the right places, which, if you don't know, can be incredibly hard. I think there's definitely young people who already work within the NHS. There's connections you can make through different integrated care boards. I know in North Eastern Yorkshire, the region we have here, that I've been doing a bit of work with. It's all about just sort of contacting the young people that you already know sometimes. And then I think this could also be quite a good question for Callum, who I work with and does the recruitment for the youth board members. I know for when I was recruited, it was through reaching out to colleges and schools and finding young people through there. You can often find young people through the youth forums that have already been set up. So I guess it is just about using your connections and looking where young people would normally be. So just for different trusts in the NHS and sometimes even schools and colleges.
Fabulous. Thank you, Kerrie. That's, I think,
Thank you.
really comprehensive answer. I'm going to bring Simon in quickly, and then we've got a question in the chat, and then I'm probably going to have to draw it to a close. But Simon.
Yeah, Kerrie's answered really well about that. And I think from NHS England perspective, we've spent a lot of time making sure that we try and really reflect the population group of children, not so there's a mix there. So what the risk is that you end up with people who want to garnish their CVs from upper middle class backgrounds, not to be blunt about it. And that's not what we want to see. We want to get a truly reflective voice. And hopefully Kerrie sees that in the group that she reflects. I'd just say at Alder Hey, we've got a really good children youth young people's forum. Every consultant gets interviewed by them, which is, I'm reliably informed, is the most difficult interview anyone ever has, because they always like to quick and get the message right. So it's so important to get that children and young people's voice.
Thank you so much, Simon. And the question I was going to come to in the chat is around Kathy Bayard asked the question about the Times Are Hard questionnaire and that Barts have used, and whether this was developed by the trust or elsewhere. So I'm going to bring Kath in on that one.
So this was very much developed by one of our safeguarding nurses and one of our consultant paediatricians, and it was done in collaboration with families themselves around challenges that they were facing and issues that they felt might be helpful to actually ask other families about. So it's very much done in partnership, and it's currently being tested. I'm desperately hoping that they are going to publish that work, because I think it's really exciting, because there's been lots of learning. As I mentioned, with regard to the challenges in relation to health literacy, we know that the average reading age of adults across the UK is around about 9 to 11. So there have been some issues there. But also it's really built confidence in staff having conversations around these issues as well. And they've also done some signposting information and linked in with local authority colleagues and also voluntary sector colleagues. So there have been lots of spin-offs from this. But if colleagues actually want a copy of that, I can absolutely connect you up and we can share that draft, but it's very much work in progress. But it's been a really energising quality improvement programme that has been led directly by families and by clinical staff, which is really great.
Thank you. And I'm going to bring Ajit in now.
Just very briefly, I wanted to make this point earlier, just hugely commend Jude and Jenny for the work. And it just shows how national strategy is connecting at a really granular level of detail. But what was intriguing was the point about sustainability. And I guess in some ways it's a question back to you, Saffron, if I may. I hope I'm not breaking with protocol. That the tension in trust boards is that there's no longer an argument about the why of all of this. Everybody knows the why. It's more about the how. And often there's a tension between the acute pressures on providers. Certainly in my trust, there's a real need to meet the acute pressures and operational challenges, even though people recognize that the right way to solve that problem is to actually do the sorts of things that we've heard outlined today. And that's a real tension for all providers, I think, between the acute ask and the fact that that then prevents us from doing the things that we know long-term are actually the solution to the problems that we're trying to solve. And I'm not expecting you to answer that necessarily, but I just want to call that out because I see that and sense that in our trust board.
I think it's absolutely right. It's absolutely the right observation, and it's something that is so clear because we collectively know, anyone working closely in healthcare knows that getting it right for the people who need most help is actually getting it right for everyone and solving the challenges and the problems. And I think what we have to continue to do, and it's something I certainly feel incredibly passionately about, but it's about feeding in those messages at every level in every forum, whether that's, NHS England doing that. And we know the brilliant work that Vol has done, and clearly the brilliant work that Simon is doing in terms of that national strategy. But actually, we do also need to make sure that we get that message through to politicians, to the media. We need to feed those beasts with the different messages as well. But there is also a kind of, what's the realpolitik around this? Well, the realpolitik is that people often are kind of more focused on waiting times and ambulance handover times rather than getting to the root cause of the challenge. And, I would continue to flag some of the issues that we've been calling out for a long time about, the ongoing cuts to the public health grant, which have significantly undermined those broad efforts, which I know would feed in really effectively to the work that's going on. So it's a massive question, and one that we are grappling with, and certainly have health inequalities messaging at the heart of what we do. So thank you for that question, and thank you for the prompt to respond to that. I'm going to thank all of our speakers now. So Jude, Kath, Ajit, Kerrie, Jenny and Simon for their fantastic contributions. And I do just want to quickly finish by I think what's come through for me in this conversation is this real sense of it's a bit of what I said before, if we get it right for the people who need it most, then we do create bigger solutions. That line that we are seeing through from the strategic approach to the delivery on the ground and actually helping children and young people, I think is absolutely critical. And then the kind of the feedback in from seeing the child or young person themselves, seeing their families, seeing their communities, seeing the organisations that work around them as being absolutely critical, has really, really, I think, landed with me today by seeing all of these examples, hearing the questions, hearing from Kerrie in particular. And I think that the quote I'm left with is Kerrie basically saying, we need to look in the right places. If you want to find the young people who can contribute, you just need to look in the right places. And I think that's a message for all of us. So I am going to close it there. You've got the feedback form, which we do ask you to complete, the evaluation form, and you can scan that on the QR code. We will make the session recording, presentations and post-event resources available in our email, and they will post-event email, and they will go up on the website. And I do just want to thank the speakers again, but also all of you who came along for listening, for contributing and participating in this. And I will leave it at that. Thank you. As Simon said, it's a sunny lunchtime, and thank you for spending it with us. I've been hugely inspired by what I've heard, and I hope you have too. Thank you.